I want to introduce myself first. So my name is Mike Randol. I am the Medicaid and Health Services Executive Director for the state of Montana. Have been here for about 4 months. Have enjoyed my time so far. I appreciate the opportunity here to speak with you. I kind of share a little bit about myself. Prior to joining the state of Montana, I was with Cerner Corporation for about a year as a strategic director for Medicaid, and then prior to Cerner, as many of you probably know, was the Medicaid director for Iowa for almost 3 years, and then Kansas before that for about 5.5 years. So all told, 3 states so far, almost 9, 10 years of experience as a Medicaid director. Just wanted a few brief comments with respect to behavioral health overall. I know that the challenges faced by members in Montana, I want you to know they're not really unique to not Montana. They're faced by different states, different programs. They all are facing some of the same challenges. Primarily one of the big ones is access challenges, whether it's a workforce issue or transportation. Telehealth has certainly helped with that process and those challenges. And we will continue after the public health emergency to have telehealth services for the most part. There may be some changes. We are still evaluating all of those flexibilities we asked for during the public health emergency, and then determine what we're going to continue with. Certainly, as a frontier state, which I'm finding out, so really frontier, those challenges are somewhat exacerbated, especially transportation. It's very difficult to find those services, transportation especially. But that's one of my priorities too, as I've been looking at all the programs here, is looking at our transportation services and seeing what we can do either from a policy perspective or looking at potential other opportunities to really enhance that transportation, the ability to utilize that non-emergency medical transportation. I also want to share with you as whether it's a fee-for-service state or a managed care state, those same challenges exist for both care delivery models. With my experience in Iowa and Kansas, as you know, those were both managed care states. It was there were opportunities to work with the managed care organizations to incent them to really ensure better access to care, transportation, and so on, but also to be able to integrate behavioral health and acute care. You would do that through alternative pay models, some type of value-based care, in lieu of services, value add services, those types of things. But I just want to share with you too, finally, for me, access to appropriate behavioral health is extremely important. I know working with Rebecca and her team, it's a high priority, not just for myself, but I know for the administration. Obviously with the HEART initiative and working with the HEART waiver, the additional crisis services, we will continue to move that forward. And overall, I believe that will improve the behavioral health for our members. So with that, Rebecca, I'll turn over to you or whatever the next step might be.
I'm Rebecca to camera, and there are a lot of you in this room who I don't know. And so I just want to give you a little bit of an overview of my role within DPHHS. I'm the administrator for the Behavioral Health, not pay attention, and Developmental Disabilities Division. And that is a new division that was created by our previous director, Adam Meyer, about a year ago as part of a larger department-wide reorganization. And what he did is he took all of the community-based programs for behavioral health services and developmental disability services and put those into one division, which is the BHDD. And then he took all of the facilities and institutions that were previously shared amongst a couple of different divisions and put those all into their own separate divisions. So, for example, the state hospital, MCDC, the intensive behavior center, those used to be spread across a couple of different divisions, and they are all now within one facility-specific division. and that is headed by Will Evo. He's a fabulous resource to the state of Montana. He's doing some great work on looking at all of the facilities, and really having those facilities together in one division is letting us as the state look at what role in our continuum of care do each of those facilities play. As far as BHDD, we have all of the community-based behavioral health services across the entire state. So whereas previously the Children's Mental Health Bureau and all of the adult behavioral health services were in separate divisions, they are now together in one division, which is really nice for continuity of care, for collaboration, because one of the things that we would see, particularly as kids started to age out of children's services, is they would often drop off that cliff. And part of that was because there's a different set of requirements to receive behavioral health services as an adult than there are as a child. But it was also exacerbated by the fact that those two programs were operated under different divisions. And as much as we really try and break down silos and collaborate and work together across the entire department, it's a lot easier to get things done within your own division. So we're really excited about that opportunity. Another opportunity that this combination gives us, this new division, is the opportunity to more effectively utilize our block grant funds. One of the things that we found that would often happen with the block grant dollars is they wouldn't all be spent out. And at the end of the federal fiscal year, the previous administrator would come to me and say, hey, I've got $700,000. Can you spend it, and can you spend it quick? And that's not the way to spend money, and that's not the way to make plans. And so I think having, again, the Children's Mental Health Bureau now have much more access to the block grant dollars, allows us to really focus on early intervention and prevention, which we all recognize as being kind of the ideal time to start addressing behavioral health challenges. The other nice piece is that we now have all of the substance use disorder services in the same division as the behavioral health services. So previously, children's behavioral health and children's substance use services were separate. And the two did not talk to each other, despite the best intent. And we all know that there's a lot of co-occurring substance abuse with behavioral health diagnosis starting at a really young age. So I think having, again, the Children's Mental Health Bureau have access to all of those substance use services is going to make a big difference in the way that we're incorporating our children's behavioral health care with our children's substance use care. So that's kind of an overview of the division. It's a large division. It's a lot of work. I think one of the challenges that we're currently facing is finding staff to do all of the work. We've had some pretty significant turnover of late, and I know all of the providers in the room can relate to that as well. The state is certainly not on its own with experiencing challenges and hiring good folks to do really hard work. I do have some really promising internal staff though, and do intend to fill some of my major vacancies over the next couple of weeks. So glad to be making that progress, because we don't want to see the good work that's happened in the past come to a halt. So we're really focused on getting all of our positions filled and making sure that we have the staff capacity to do the work that needs to be done. One of the bodies of work that Mike mentioned that's really important to both the department and to our current administration is the HEART initiative, and that's the Healing and Ending Addiction Through Recovery and Treatment. And that is Governor Gianforte's very broad-based initiative aimed at filling the gaps that currently exist within the behavioral health and substance use services continuum of care. And as you all know, there's some pretty significant gaps. He's looking at the entire continuum of care, from early intervention to prevention to crisis to treatment to recovery. So really trying to identify where all those gaps fall and looking at a set of services that can be put in place to address those gaps. The HEART initiative consists really of two primary bodies of work. There's a broad HEART initiative, and then within that broad HEART initiative is what is referred to as the HEART waiver. So if any of you have been following these conversations, I think it gets a little bit confusing understanding what is the HEART waiver and what is the HEART initiative. So the HEART initiative is a broad-based set of work, and it includes a variety of different focuses, including providing funding for behavioral and substance use services to tribal communities. There's a focus on providing behavioral health services in jail-based settings so that we can get those settings into that community, because that is not an area where Medicaid can reimburse for services, so it's a particularly vulnerable area. We're also looking very closely and spending a tremendous amount of time on revamping our crisis response system. I know in this room you guys all recognize the challenges that currently exist in our communities with our crisis response services. So really looking at implementing a crisis now model, which is someone to call, someone to respond, and somewhere to go, which sounds very simple until you start actually trying to operationalize each piece of that. So we did recently contract with a group, they're called Witchy, and they have done a very thorough analysis of the crisis system within Montana and have recently provided us with about a 120-page report. So we're in the process of reviewing that report, and we'll be hopefully moving forward on some of their recommendations relatively soon. I think another exciting piece that we're looking at that you're going to hear more about tomorrow from Mary Windecker is the CCBHC model, and that's been mentioned a couple of times today, but the Certified Community Behavioral Health Center, and is that an answer to filling some of the gaps that are currently existing within our behavioral health system. And then we have the HEART waiver, which is an 1115 waiver, which means it's a document that we have to fill out as the state to apply to CMS to allow us to do things that are different than what is required by the federal CMS guidelines. And there's a couple of different components within that 1115 waiver, and they're pretty progressive, which is why we're having to look at doing a waiver. One of the components is implementing contingency management, which is an evidence-based practice that's been shown to be very effective for folks who are struggling with methamphetamine addiction. And so we're really excited about that. And anticipate receiving CMS approval to implement that model relatively soon. Another piece that we anticipate getting approval on fairly quickly is our tenancy support services. So having in place Medicaid reimbursement for folks who are struggling with homelessness or who are at risk of homelessness, and has come up a couple of times in today's presentations. That's a challenging factor when accompanied by mental health issues. And we recognize that somebody's not going to effectively be able to engage in mental health treatment if they don't have a safe, stable place to live. So really looking at moving beyond just sort of the standard conventional Medicaid treatments to expand those treatments to have a more wraparound, holistic component to them. One of the components that we have received CMS approval on is the ability to allow facilities that have more than 16 beds receive Medicaid reimbursement for substance use treatment. Previously, these facilities were excluded by the IMD exclusion, or the Institutes for Mental Diseases exclusion, and it was really limiting the number of beds that were available in Montana for residential substance use treatment. So we did receive approval of that waiver component and have been able to implement that. So that's adding to the number of beds we have available in our community to treat folks who have substance use disorders. And then finally, and what has kind of become my pet project, is something that's really exciting, and it is implementing Medicaid reimbursement for folks in either the Montana State Prison or the Montana Women's Prison 30 days prior to their discharge. And a big piece of that work is linking them up while they are within that 30 days prior to discharge with community providers that are going to be able to continue their care once they've discharged. Because one of the things that we see, as I'm sure you all know, is the challenges that people face that have been receiving mental health and physical health treatment in a correction setting. When they discharge, oftentimes they don't have the warm handoff that they need to be able to continue that treatment. They end up in the emergency room or the state hospital, or they recycle back through the criminal justice system. So this is something that we're working on very closely with corrections. It's very, very challenging work because we not only have one bureaucracy, but we now have two bureaucracies that we're having to navigate and make some fairly progressive changes in. So it's challenging, but it's work that if we can accomplish will make a tremendous difference in the quality of life for people who have mental health issues, who also have been incarcerated. So we're really excited about that work. That is the piece of the waiver that is going to take the most time to get approved by CMS, and that is because of its progressive nature. California is in the process of having a comparable program approved by CMS, but they are also still in the negotiation phases. We have been being promised by CMS since the beginning of the summer that we are going to be getting a Medicaid director's letter on what the scope of those covered services needs to look like. They promised us fall. It's fall. We haven't received it, but we are still hopeful that we're going to get it within the next month or so, because that's going to get a sense of what CMS is going to be willing to approve providing reimbursement for as far as the services being delivered that 30 days prior to release within the correction system. So I know that that's quite a bit of information, but I just, I want to wrap up, and I want to give you guys the opportunity to ask questions, but just by saying thank you for the invitation to be here today. I started my career as a direct care service provider in a psychiatric crisis unit. I couldn't even get a full-time job at the time. I had to get a relief position. Those jobs were so in demand. So it's really interesting to me to see how far we've come from that, because I went into that job with the understanding that that was going to be my career. And I've worked my whole life in social services, and I'm now doing administrative work. So coming to events like this and getting to meet clients and advocates and counselors and providers and people that I don't necessarily always get to come into contact with is really, really refreshing. And I just want you guys to know that both Mike and myself are really open and anxious to get feedback from you guys, because we sit in our offices 80% of the time doing bureaucratic work and don't always know what the system in actuality is feeling like to the people who are utilizing the services. So thank you for being here, and thank you for being advocates. And Mike or I are open to questions.
Just a second, and I guess I want to say, be nice with your questions. Be nice with your questions. Like we had the head of DPHHS a few years ago where I did have to cut somebody off and almost boot him out of the conference because he wasn't treating them with respect. So we know things can have a lot of emotion, but we're to work to have really nice questions.
So Rebecca, you're always safe with me.
Oh, Gary, you're the main person I'm worried about.
2 easy questions.
Okay.
So you're talking about the crisis study, the crisis from which.
Mm-hmm.
So my first question is that study going to be made public?
So my understanding, and we're in the process of reviewing it internally, is that assuming that there is not any proprietary information included in that report that may need to be redacted, that yes, that report will be public.
Then the second question is, so do you have any idea when the Marcel and Alvarez study will be completed? Because I'm going to say a good thing here.
Mm-hmm.
I was in the interim committee and listened to Diane Rafferty, and she was the most impressive consultant I've ever heard. Because she gets it. So I'm anxious to see what that report says. And I just any idea when that will be available.
So just for some background for folks, Alvarez and Marcel is a group that the department is contracting with to come in and review the functioning of all of the state-run facilities. Obviously, with the state hospital losing their CMS certification, the focus has been primarily on the state hospital, but they are also looking at the Intensive Behavior Center and MCDC and the Montana Lewistown Nursing Care Center. So all of the facilities. Their scope of work has been extended, so I don't know if there's going to ultimately be a single report released, but something will be released. I just don't know when.
All right, so in the middle.
Yeah, I was wondering if there was any studies on, or peer studies on what it means actually to be impoverished in dealing with these Medicaid sources. So, from my personal story, I pay $800 a month for rent. To get Medicaid, you have to qualify for a certain amount. But my landlord needs a copy to sign to send to Medicaid, and to get into most apartments, you need to make 3 times the income to get into that apartment. So at 800 times 3, that's $3,600. All of a sudden now I have so much Medicaid, which basically disqualifies me from Medicaid, because that shows that I need to Medicaid. So it's always this revolving circle of disqualifications just to get into a cheap apartment. So you almost always have to be playing the game of poverty in everything. So I'm wondering if there's researchers out there that are talking to people like myself who are living this game that I call it. I mean, that's what it is. Where it's very, very hard. I make $18 an hour. I work 40 hours a week. That's $2,800 a month, give or take, before taxes. So that's not even enough to get into an apartment, but it disqualifies you for Medicaid, so I have to work part-time, just like if I had illness medications and stuff, pay for it, work doesn't cover it. So are we talking to people that are lower class who, this is the life, this is literally the difference between suicide from
So that's a doozy of a question. I was warned you were going to ask these kinds of questions. No, I don't know if, do we have to type? I would like to give Mike the opportunity to respond to that.
Can you repeat the question to some degree?
Yeah.
Just about the.
So, and please jump in here if I am not summarizing what you said accurately, but the question was the relationship between poverty, mental health, behavioral health, and Medicaid, and how there's a tremendous amount of documentation that has to be provided when you are on Medicaid, and how if you're living in a cycle of poverty, it makes it very difficult to have to be continuing to jump through those sort of administrative hurdles while taking care of your behavioral health, while meeting your landlord's requirements for documentation that you're receiving, housing subsidies, just the cycle of poverty and mental health issues. And really it's all physical health issues, right? It's not just mental health issues.
Thank you so much.
Thank you.